Thank you for coming today to our special guest lecturer's talk on nudging West Virginia communities toward cultures of health. And it's really my not only pleasure, but it's my privilege to share with you guys Alan Mills. And Alan has become a dear friend and is somebody who is incredibly talented professionally, but as talented as he is professionally, his personal attributes are much greater. So he's really one of the finest people I know. And Alan has a really interesting background, and I'm not going to go through his CV in detail, but Alan is a clinical practitioner, practices naturopathic medicine, and is also an actuary who is working with a lot of insurance companies to try to reorganize and reorient how they look at risk. And I really got to know Alan as I became interested at Ohio State University in personalized medicine and how we could facilitate and improve health. And so I, like many people in the room, have a network of people I know. And I said, I really want to find the expert in the country around using complex systems approaches, which basically means like how you look at things in nature, to try to understand how I can architect healthy communities. And this is who I was sent to by 3 separate individuals. And so I called Alan kind of out of the blue and said to him, here's what I want to do. And Alan said, well, that sounds wonderful. And he said, I'm going to be in Chicago and I'll just fly in. And we had lunch. And I have to say, I was sold on not only his skill, and he's written a primer on using approaches that he'll talk about today, using different modeling approaches to be able to help us understand how we can architect healthy communities. And I'll be happy to share that because I actually think it's the best thing in this area I've read. It's really a stunning piece of work that is both understandable and very, very smart. Alan has had a lot of experience working with state government, with health insurers, with large employers, and also he's had a lot of management expertise, and he also has an engineering background. So, you know, the more I learn about this guy, the more amazed I am, but his humility and his altruistic nature of trying to do work that helps other people is a thing that really inspires me every time I'm around Alan. And as opposed to what we started to try to do in Columbus and never really finished, we're going to do something together here that's going to be amazingly good for the citizens of our state. And we both need all of you guys to help us do that. So with that as an inadequate sort of listing of all the great things he's done is my good friend Alan Mills, who I'm really very delighted to be able to introduce to you today.
Clay, thank you very much. It is such a delight to see Clay again this morning. I just, doesn't he just make you smile when you see him? I just really love being with him and talking with him. And I've had such a fascinating morning this morning. I've begun to meet some of you, some of your colleagues, and I have to tell you, I've just been blown away. There's such enthusiasm here for helping other people and helping people to become healthy and helping the state to become healthy and improving it. I've been just amazingly impressed because that's my passion. It's to help people become healthy. And I've taken that passion to communities. I'm very interested in helping communities become what I'm calling cultures of health, so that the community supports itself in becoming more healthy. And that's what I'd like to talk with you about today. How do we help the communities in West Virginia to become cultures of health? And in my discussion, what I'm going to try to do is to communicate a view of the world or a view of what I'm going to call health systems that I think is very different. And for me, it's been very useful in helping other communities, helping other states. It's a sort of a worldview, a perspective that pays off. And I want to share that with you and see what you think about it. So first of all, can you hear me okay? Okay, good. And I would encourage you, as we talk this morning, please ask questions. Don't wait till the end. If you see something that's interesting to you and you'd like to pause and ask a question or make a comment, please feel very welcome to do that. So I've encapsulated what I'd like to tell you about today in what I'm calling 2 assertions. And the first assertion is, I want to convince you that West Virginia's health system is not a car. And a couple things about that. First of all, when I say health system, and I'm going to be using that term a lot today, when I say that, I mean not only the physicians and hospitals and insurance companies and the other things we think of typically in terms of a health system, but I'm thinking more broadly than that. I'm thinking about restaurants and grocery stores and parks, and are the sidewalks there so that you can take a walk? The whole system that contributes to the health of a community is the health system. So I want to convince you that Virginia's health system is not a car. Rather, it's a thing that I call, and others call, a complex adaptive system. And we're going to spend some time with that and explain what that is. So that's the first assertion. And I would like you to consider that and see how it feels to you. The second is, West Virginia, like all states, have problems in their health system. And what I want to propose to you is that the problems in West Virginia's health system cannot be fixed by our traditional approach to hard problems. Rather, I propose that we need to take a new approach, and this is what I'm calling the complexity science method, and we'll spend some time talking about that. So this is the agenda that I'm thinking of following. First of all, I want to tell you what I think our traditional method of solving hard problems is, and talk about that a bit, see if you agree. And secondly, why this method won't work to solve West Virginia's health system problems. And in a word, the reason it won't work is because the health system is what we call a complex adaptive system. And we'll talk about that. Next, I'd like to propose something to you that I think does work, or at least works a little better, actually a lot better, and that is a method called the complexity science method. I want to go through that method and then show you 3 very important components of that method. The first being something called agent-based simulation modeling. I want to show you a model, an agent-based simulation model. Second, behavior heuristics. This is something from behavioral economics that I want to talk with you about. And third, networks. Networks are incredibly important when we talk about improving health of our communities, and I'd like to share that with you. And finally, I've got a surprise for you. So let's begin. Let's start by looking at how we traditionally approach hard problems. A physician, to help a patient with a health problem, often breaks that patient's body down into components. Here it's broken down into body components, different body systems. And then we might focus on one body system and then break it down into biochemical pathways. We might even further break it down into genetic components. But the point is, we analyze. That's the first step in our traditional method of looking at hard problems. Next, we gather data. For a patient, we might gather physical data, physical measurements. We might take blood samples. We might do some diagnostic imaging, but we gather data. Then we hypothesize cause and effect. We focus on this one problem and we say, what is the cause of this problem? What is causing these symptoms? And we often go through our flow charts and find a cause, and often it's sort of a linear cause. It's a big cause causes a big effect, and small causes small. They're usually linear type cause and effects. And then once we've found the cause and effect that we want to focus on, we intervene, we give the patient something or do something with the patient that we hope will help, and then we assess the outcome. So that's our traditional approach to solving hard problems. Now, for the last 200 years or so, this method has worked spectacularly well, especially in physics for Newton and friends. It's worked spectacularly well for mechanics when they try to fix a car. They find the part that's defective and they go in and they fix it. It's worked very well. This is the method I submit to you that we use when we try to fix health systems. And I'm also going to submit that when we do that, this method does not work. And the reason is that health systems are not cars. Cars are what in complexity science we call simple systems. They may be very complicated, but they're simple systems. A health system is something entirely different. And to illustrate that for you, I'd like to show you two examples. Before we go into that, everything okay? All right. This is an example that actually deeply troubles me and one that I'm working with actively. I call it the Cesarean childbirth problem. As you know, the more natural method of childbirth is called vaginal birth, and it's when the baby is born through the mom's vaginal canal. The other typical method of birth is called cesarean birth, and this is when an obstetrician cuts through the mom's abdominal wall and into the uterus and brings the baby out. Whoops. Of every 10 women in the United States today, 7 of them give birth vaginally, more natural method. 3 of them give birth by the cesarean birth method. And one of these 3 women undergoes this cesarean surgery unnecessarily. There's no medical reason whatsoever for this woman to undergo such surgery. In the US every year, 500,000 women undergo cesarean birth unnecessarily. In West Virginia, I estimate it's probably on the order of 3,000 women a year undergo this surgery unnecessarily. That's not necessarily a good thing. The World Health Organization says that a reasonable percentage of cesarean births in a country should be somewhere around 15%. People quibble, some say 10, some say 17, but it's around 15%. Anyone know what it is in the US? It's about 33%, 1 out of every 3 women, as you saw in the slides. And in West Virginia, it's a little higher, actually. So the rates are very high in the US, and they're highly variable. From country to country, from state to state, from county to county, from hospital to hospital, from obstetrician to obstetrician within a hospital, rates vary greatly. The high rate is often twice or more times the low rate. High variability. Many moms and newborns are affected. As I said, in the US, 500,000 moms every year. And this leads to very great potential health risks for the moms and the newborns. One of the most interesting things that researchers are beginning to tease out of this problem is that we're beginning to think that there's high correlation certainly, but perhaps causation between cesarean birth and the obesity among children in the US. So if that's true, then you begin to have a vicious circle, because obese moms tend to have more cesareans. And if they're delivering children who are obese, you're beginning to have a vicious circle. But it leads to unwarranted health risks, and it leads to very high expenditures. In the US, it's on the order of $1.5 million a year. We really don't need to spend $1.5 billion a year. In West Virginia, I estimate it's probably on the order of $10 million a year. So that's the cesarean childbirth problem. It's a major problem, and we've known it for 20 years or more. Many have tried to solve this problem. For example, in Taiwan in the year 2005, the government looked at their cesarean rate. They saw it was 43%, and they said, we really should do something about it. And so they used the traditional analytic method, and they discovered that it looked like obstetricians were being greedy in Taiwan, that the government paid more for cesarean births and less for vaginal births, and so the obstetricians were going for the cesarean births. So they were going to fix that, and what they did is they brought the level of vaginal birth payment reimbursements up to the level of cesarean birth payments. And they thought, well, now there's no financial reason at all for this to happen. Certainly it's going to equalize, and the cesarean rates are going to drop. Any guess what happened? The cesarean rates went up. Interesting. So in the US, many have tried to solve this problem. Many states have tried to solve this problem. And they've done things like issue edicts. They've done this in Washington, for example. A major commission came out and said, don't have this variation anymore. They issued edicts. And we've provided childbirth guidelines to obstetricians. We've fed back performance statistics to hospitals and obstetricians. We've published these statistics publicly. We've reformed provider payment methods. We've educated payments. And actually on and on and on. Have any of them worked? No, they haven't. Why? In fact, AHRQ in 2012 published this massive report, more than 500 pages, that went through these strategies that I just mentioned to you, plus many more related to the cesarean childbirth problem. And this was their conclusion. No single strategy was uniformly successful in reducing cesareans. Strength of evidence was low to insufficient for all strategies. So the method we've been using has not worked for this major problem. Why? Let's look at another example. In 2002, in Maine, the agency that controls Medicaid in that state, called Maine Care, had a very big problem. They were spending so much on drugs in Maine Care that it was bleeding the state's budget dry. And they wanted to do something about it. So they analyzed the problem, gathered data, and what they hypothesized was it was, again, the physician's fault. And what was happening here was that physicians were prescribing too many kinds of drugs and too many high-cost drugs. So the solution that the Maine Care agency came up with was to promulgate a drug formulary. And a formulary, as you know, it's a list of drugs that before any physician prescribes a drug, the physician has to call in and get permission to use the drug, or if it's not on the formulary, and they have to use the drugs on the formulary if they possibly can. So the hope was, and this was sort of the logic they went through, that if they did this, then physicians would prescribe fewer drug brands, and they would prescribe lower cost drugs, i.e. the drugs on the formulary, and then Maine Care could negotiate lower drug costs with the drug companies, and the drug companies would charge less for drugs, and the budget would be happy again. So, do you think this worked? It didn't. What do you think happened to the expenditures for drugs and for this program in Maine? It went up. So interesting again, this method did not work. And indeed, in many areas of healthcare, this happens again and again and again. We try our best to produce these wonderful strategies, and what they end up doing is producing the opposite of what we want. They produce perverse effects. Why? Let's look back at Maine Care. Here's why. For Maine Care, it turned out that the people who analyzed this problem focused in too narrowly. Their purview was not wide enough. If they had taken in more agents involved in this problem, that is hospitals and patients and drug companies with all their behaviors, they would have seen that what was bound to happen was drug companies weren't just going to sit still and have their income reduced. They were going to start advertising non-formulary drugs to entice patients to want those drugs, and so they would put the physicians in a difficult place. Patients were going to be upset. They were going to complain. They were going to sue. And while their physicians waited on approval for drugs for these patients, they were going to become sicker, and they were going to require more drugs. So physicians got upset, and they said, to heck with this, we're just going to send our worst patients to the hospital or to specialists who are not part of the formulary. So all these things started to happen. The mistake here was that Maine Care viewed its system sort of like a car, that we were going to find this part of the car, physicians in this case, and we were going to fix them, in this case with a formulary. But the health system in Maine is not a car. It's alive with amazing interconnections and so many types of different agents. We're just beginning to list them here. It is not at all a simple system like a car. And if you are going to try to change the behavior of the system as a whole, you need to widen your purview rather than focusing it down. The system in Maine is what is called a complex adaptive system. Absolutely, I wish you would. Oh, yes, you need to, if you would, speak into the microphone.
So I come from the HIV world, so this is going to be relevant to that. But with the Affordable Care Act, what's actually happened as people, get insurance or go into Medicaid, at least in the state of New Jersey, they've actually done just that. And whereas, Truvada, which 80% of the patients with HIV in this country are on, it's now you have to get approval. So what we've done is increased. At the time I left Rutgers, we had a nurse that, was working full-time for approval. So, given that, now you have the Affordable Care Act, and it looks like that unsuccessful model is being propagated. So why is that? And do you think the Affordable Care Act is actually just going to promote, this kind of nonsense?
Well, my short answer to that is that federally, as well as with states, policymakers are not following what I think is a better way to formulate policy. Very often, the way policy is formulated in the United States is it's a shotgun approach, and it's an approach where we think it's a good idea, let's try it and see if it works. As we'll see in a minute, I think there's a much better way, and I do think there's a high possibility that will fail, because it's interesting. Maine Care failed, the formulary process there failed. It's failed in so many insurance companies that have tried the formulary approach, but we don't seem to learn. And I'll say one other thing, that each circumstance is different. You can't just say, well, Maine Care's formulary failed, so all formularies will fail. It really depends on the circumstance. It depends on the players and who's involved. So a real answer to that question is we would have to put this problem through the complexity science method and see if it was a good solution. And we'll get to the complexity science method in just a moment. Is that helpful at all? Okay, all right. So as we saw, the cesarean childbirth methods of solution also failed. And the reason for that, as I think you're beginning to see, is that the healthcare system, the health system in Washington, is a complex adaptive system. It is a system that's evolved over years and years to very efficiently take care of childbirth in the state. So you don't only have obstetricians, you have technology, you have fetal monitors, you have laws, you have midwives, you have birthing centers, you have hospitals, you have the people themselves have fixed ideas about, moms themselves have fixed ideas about how they want to have their children. So it's very difficult to analyze in and find a solution that's going to work in such a system. It's very unusual to find successful solutions that way. Let's look at West Virginia. West Virginia's health system is also a complex adaptive system. And I would actually go further than that and say that, especially as I've been learning this morning, West Virginia is not one system. It's probably multiple systems, multiple communities, because West Virginia is not one monolithic state. It's got many different communities in it. So West Virginia has many complex adaptive systems, health systems in it. But each of these has two main elements, and this is when we're going to start to understand what a complex adaptive system is. The first is agents. Agents are the actors within a system. And within the West Virginia's health systems, certainly these are some of the agents: hospitals, consumers, of course, the people, medical schools, researchers, doctors. But as I mentioned before, it's also grocery stores and restaurants and parks and all the other infrastructure that supports our health. These are the actors within the system. Now, these agents are generally autonomous. If you think about it, there's really nothing that controls all the agents within West Virginia's health system. They're heterogeneous. That is, one obstetrician may be very different from the obstetrician next door. They're adaptive. They learn and they evolve, each of them. And as we'll see more, we'll talk about more a little bit later, they're boundedly rational. That is, all of the agents are not perfectly rational. In fact, probably none of them are. The second major element of a complex system is networks. Agents are related to each other through networks, and these can be friendship networks, they can be family networks, they can be consumer-type networks where consumers purchase from certain stores. They can be peer networks, colleague networks, employee networks, but these are very, very important, and we'll talk about that a little more in a minute. Now, let's consider the complex adaptive system as a whole. Here are some features that complexity science have learned about these complex adaptive systems. They tend to, all the way from ant colonies up through human populations, they tend to have some features in common, and here are some of them. First of all, they're self-organized. That is, there is no central controller as I mentioned, of the West Virginia health system. And here I'd like to have you listen to one of the complexity science pioneers talk about this. Nobody. That's Steve Strogatz. In addition to being self-organized, complex adaptive systems are also self-preserving. That is, they seek to maintain their homeostasis and survive. As one works to improve the health of a complex adaptive system, it will push back and it will say, I don't want to change, I want to stay in the status quo. So it's not an easy thing to change the behavior of a complex adaptive system. They're evolving. They continually learn and evolve, usually over long periods of time. We cannot expect to go in and change a community in 3 months. They're capable of tantrums. That is, these complex adaptive systems have relative quiescence over long periods of time, and then, boom, something's going to happen, like an epidemic in a health system or the Accountable Care Act. They're nonlinear. That is, small perturbances can cause very large effects in complex adaptive systems. This is the famous butterfly effect. And perhaps the most disconcerting characteristic of all about complex adaptive systems is that they're unpredictable. No matter how hard we try, if we try to predict the future of a complex system far into the future, it will not work. And one of the reasons is that they are nonlinear, they do have tantrums, and they have these things called black swans that Nassim Taleb was talking about. They're unpredictable. So I hope that I've convinced you that West Virginia's health system is not a car. It is not a simple system. It's a complex adaptive system, and we have to treat it as such. And we have to solve its problems in a different way than we solve the problems of a simple system. Okay, let's take stock of where we are and our agenda. So we've talked about our traditional method for solving hard problems and why it won't work for West Virginia's health system. And that is because West Virginia's health system is a complex adaptive system. So I hope that you will now consider the first assertion that it might be true, and that is that West Virginia's health system is not a simple one. Rather, it's this thing we call a complex adaptive system with all of the features of a complex adaptive system. Okay. Now, let's look at a method that I submit will work in a complex adaptive system for solving some of its problems. It's called, as I said before, the complexity science method. Here it is. It's 4 steps. It looks maybe similar to the traditional analytic method, but it's really quite different. And in the first step, instead of focusing in, instead of analyzing, the complexity science method says, do the opposite. Open your purview. Look at every agent, every behavior, every network that relates to the problem you have at hand. Identify them all. Second, when you develop an intervention for solving this problem, keep in mind 2 very important things. One, that the agents within the system are not rational, that they use what are called behavior heuristics in their behavior, and that we should take that into account. The second major thing is that people act within networks, that networks are incredibly important in determining the outcomes of a complex adaptive system, and we need to take them into account.
Yeah.
Yes?
Can you define heuristics for the people in the room?
Sure. Very simply, heuristics are rules of thumb, and we're going to talk about some in detail in a moment. But these are ways that we're built, our minds are built to make our way through life. And what's very interesting about these rules of thumb is that very often they are not at all logical. They do not make sense, but this is how we operate. And if we don't take this into account, then we're not going to be effective in our problem solving. The third part of this method is that once you come up with a proposed intervention, test it. Test it in a lab before you try it out on people. And the lab that I'm suggesting that you test it in is a computer lab. It's something called Agent-Based Simulation Modeling. And we'll talk a lot more about that in just a moment. Steps 2 and 3 are massively iterative. You will go into your lab and you will find that a certain intervention will not work. And so you will come back with another intervention that is modified. And you will actually go through hundreds of these steps. We don't do that when we treat a patient, do we? Or when we fix a car. We don't iterate hundreds of times. But what this method can now do is it can be automated so that we can have help with computers to help us iterate through these solutions. And finally, once we find an intervention that looks like it passes muster with the lab, with the computer, then we intervene and then we assess. So, let's now talk about, we just talked about complexity science method. Let's talk about these 3 components of the complexity science method. First of all, agent-based simulation modeling. And to help you viscerally get why we need agent-based simulation modeling, I'd like you to take a look at this. This is a checkerboard, and there are 2 squares on this checkerboard, A and B. The question is, which is lighter in color, A or B? Who would say A? Who would say B? Did I hear C? C is correct, actually. It turns out that these 2 squares are exactly the same shade. Here they are. And I did nothing. All I did was take away. So we go back. They're exactly the same shade. And I tell you, I can look at this, and I have looked at this, and I still swear that one is a different color than the other. But they're not. And the point here is that our sense of sight is one of the most developed faculties we have, and it can be so easily fooled. And I know you've seen these before. We're so easily fooled in our sight. If our sight can be so easily fooled, then what are we going to do about our faculty of reason when it's applied to something as complex as a healthcare system? We need aids. For our sight, we need microscopes and telescopes. We need aids. And that's exactly what the agent-based modeling is. It's an aid. Agent-based simulation modeling is a type of computer simulation where we model all the agents and all the behaviors in a system and all the networks from the bottom up. We look at individual agents and how they would perform, how they would react under certain circumstances. It's like a computer lab, and I'd like to show you an example of one. This is a model that I prepared for the state of Washington called the Childbirth Policy Simulation Model. Its reason for being was to solve the Cesarean childbirth problem, which I mentioned to you earlier. It includes many agents within the health system of the state of Washington. It includes more than 80,000 individual women giving birth a year. It includes 650 obstetricians, midwives, all the midwives in the state. But the point is, it includes every single person and every behavior of that person that informs the cesarean birth problem. So it's very detailed, an extremely large model. And a neat thing about agent-based simulation models is once you model each of the agents, you can begin to visualize them. So you can have a model that shows policymakers what's actually happening in a state, county by county, city by city, street by street, as far as this problem goes. And here we've got, this is a month-by-month simulation, and you can see policymakers can begin to see which hospitals are having abnormally high cesarean rates, where the abnormal rates of cesarean birth are in the state. They began to see how some women in the state travel hundreds of miles to find an appropriate hospital to go to so they won't have to have a cesarean birth. It begins to uncover a lot of problems. This particular model is, like most agent-based simulation models, it shows you this visual aspect of the problem, but it also, in number 1 here, it digs very deeply down into financial results, population health results. It shows you detailed results about what's actually happening in the state. Number 2, you can click on any point, any agent within the simulation, and it will show you details about that agent as you move through the population. This is very helpful for policymakers as they begin to try to understand what is actually happening. I'll get to you. 3, you can, on this GIS map, you can focus in on any particular part of the model. So say someone wanted to focus in on Seattle in this model, they could really focus in and see exactly what's happening in Seattle. So it's a tremendously robust and versatile model, but that's not the most important thing about it. The most important thing about this is to watch stakeholders and policymakers help me to build this model, because we discuss the agents that should be involved and what their behaviors are and how would they behave if we did this certain intervention. The policymakers learn so much by virtue of building the model, and then as a just sort of icing on the cake, what they get are these wonderful results, these financial results that come out, that there is no way a human mind could keep all of this intact and come up with reasonable conclusions. So this is an example of an agent-based simulation model. And by the way, this model led us to something that we're beginning to look at much more closely in Washington, and that is, why not build birth centers right next to every hospital in the state? No one ever thought of doing that. But this model led us to that conclusion, and we're now taking a very serious look at that potential solution. So that's agent-based modeling. That's in this 3rd step of the complexity science method. Now let's look at behavior heuristics and social networks that are the 2nd and 3rd steps, the 2nd and 3rd aspects of this complexity science method. Behavior heuristics comes from behavioral economics, and behavioral economics, as probably you know, is a discipline that looks at how normal people behave under normal circumstances with normal emotions and with normal constraints. The most important conclusion, oh yes, I'm sorry, please.
I have 2 questions.
Yes.
So one is,
Let's wait for the mic.
one question is, go back to King County, where Seattle is located and where we have UW hospitals. So level 3 NICU, top hospital, of course, a mom might choose to deliver there, and especially if she's going to be high risk, she might tend to go there because she would choose that if she's at any question, might in any way might need a C-section or any other sort of neonatal, postnatal care.
Agreed.
And then my next question is, what do you do about culture and belief of both the providers and the patients?
Absolutely.
So
And culture and belief plays into both those questions, doesn't it?
It
You know,
does.
it's the
It
belief of
does.
the moms as well as the provider. It's the belief of the mom that she needs to go to that very advanced hospital, isn't
Exactly. And so that's my question when we come to, I work in rural counties in West Virginia.
Right.
And when going out there, you know, what you and I might perceive as smoking as a bad thing during pregnancy, the women out there don't perceive that. And so if they don't perceive it as a bad thing, then my attempt to try and address it is going to have to take a different approach.
I'm so glad you asked that question, because what that encouraged us to do, and we indeed did, was we had to understand how are we going to change the culture of women in Washington. Right? The culture of women in Washington right now is to go to the hospital. How do you change that? Well, you change it in a number of ways. You do it through networks, through the friendship networks of women, and there are ways to address that. You do it through media. You do it through physicians. You have to convince the physicians first. You do it through midwives. And that takes time. But that's absolutely included in the model, because it tells you how long the delay time is going to be for your model. So I totally agree with your comments. They're right on, but they are addressable, and we've addressed them. Is that okay? All right. So the most important contribution of behavioral economics is to show clearly that the main assumption of that elegant mathematical theory called neoclassical economics, that is the basis of how we think economies and markets operate, it's basically wrong. And that key assumption is called rational choice. It holds that we and people and organizations behave rationally. We behave logically. And that's simply not true. We don't. And here's Daniel Kahneman, the founder of behavioral economics, talking about the origins of economics. I wonder how often we use that heuristic substitution in what we do in trying to solve problems with health systems. We substitute this very, very complex, difficult problem with something that's simpler, and we think that will be a solution. There are many heuristics that behavioral economists, and by the way, Daniel Kahneman was the first psychologist to win the Nobel Prize in economics. Pretty interesting character. There are many heuristics that behavioral economists have discovered. Here are a few of them, and I want to just give you a flavor for a couple of them. One is called default choice. In a choice set, like on a form, most people will simply go with what's chosen as the default, what the default is. And we see that with organ donations. People wondered for a long time, why do countries differ so much in how they donate organs? And it boiled down to which choice was the default on the form when they applied for their driver's license renewal. That's what made all the difference. Overconfidence. We're all overconfident. Smokers think they will not get sick. Old people think they will not get sick. We're all overconfident. Experts think we're always correct, right? We're very overconfident. Loss aversion. We hate losing things much more than we like getting things. As a matter of fact, the psychological power of loss is about twice the psychological power of gain. And this goes on and on and on. There's so many ways that we think according to these heuristics. So how do we apply this? Well, there are many ways to apply this in order to nudge communities toward health, and some of them are obvious. For example, because people and children like the default choice, we might put the healthy food so that they're default choices in school lunches. And Richard Thaler and Cass Sunstein came up with something called a choice architecture. And they say if you're going to give choices to people, put these components in. Provide a beneficial default option, expect error, expect us to make mistakes and see if you can correct it, give feedback, clarify ambiguous alternatives, don't give complex choices because people will simply get them wrong, make them as simple as possible, and provide appropriate incentives. So that is how we can apply behavioral heuristics to nudge communities toward health. another thing that we need to include is something called networks. And because of the time, I think what I'm going to do is, most people have to leave at 1. Is that pretty much correct? Yeah. I'm going to skip this. And I'm going to show you some things about networks that, all this is interesting, but I'm going to show you some of the nubby things. So not only are obesity and thinness contagious, but we know now that smoking's contagious, stopping and continuing alcohol is contagious, and many other such addictive behaviors. So we've completed the most important parts of the agenda. And I'll just tell you, the surprise I had in mind is I have a clip of Jamie Oliver trying to improve the health of Huntington, West Virginia, and I wanted to ask you what you thought about his results there. So perhaps that would be something for you to think about. But I hope that you would now consider seriously my assertions, and that is that West Virginia's health system is a complex adaptive system, and we need to treat it as such. And to solve problems in this system, we need to use an approach called the complexity science method. And that method has agent-based simulation modeling, it has behavior heuristics, and it has networks as very important components. Thank you very much.
So Alan, that was terrific, and I know that people's mind are abuzz right now. Can you talk about using bright spots, so trying to identify areas of success as information sources about things that might work in particular sort of areas?
Yeah, in addition to these things like obesity and alcohol addiction and so on being contagious, so are good ideas. And so it's very important that we find good ideas here and abroad that will inform our problem solving. And so as we're trying to solve particular problems in West Virginia, I think it's critical that actually a first step should be research and looking at other communities that have tried to solve similar problems. This is one thing that we did for the cesarean birth problem. And what we found was that the Netherlands is one of those bright spots. They have a very low cesarean birth rate. And so we spent a lot of time trying to understand why. And part of the reason we found is the culture of the Netherlands lends itself to the cesarean birth rate they have. But yeah, bright spots are very important, and they're communicative.
That was really interesting. I thought of something different when you first used the word model. I thought of the kind of basic science models I live with, where the model's only as good as the parameters you feed it.
Right.
And for it to be of value, it has to be predictive. So you have fabulous parameters going into your model about cesarean births in Washington State. But what I missed was one test of a particular intervention and what it might or might not do. How can you predict the outcome?
You can't. And that's one thing
how do you know if it's
about...
gonna work or not?
Okay, that's one thing about complex adaptive systems you'll remember that I mentioned. They are not predictable. It's sort of like the weather. We now know that we cannot predict, and never will be able to, predict the weather more than 2 weeks out. Can't do it. And we've proven why you can't do it. With a complex adaptive system, same thing. You cannot accurately, with skill, predict how this system is going to unfold over the next 20 years. But that's no reason not to model, and then there are very good reasons for modeling. One of the best reasons, as I mentioned, is that it takes you mentally through the process. It forces you to think through in detail what might happen if you do this and this and this. And the other thing is it encourages you to think through alternative scenarios and alternative behaviors. You know, we don't know exactly how every human is going to behave in a certain circumstance. But we can postulate and we can change it around and see what impact slight changes might have on the system as a whole. So it begins to give you an intuitive feel for how the system operates and behaves, even though we know, like children, we will never predict how a child is going to behave.
Maybe I'll ask the last question, then we'll invite people to come down. Can you talk about the asymmetry of complex systems? So I think that one of the sort of the issues that's inherent to Al's question is the fact that certain parts of the system might weight differently than the other parts, and using your modeling system to try to understand those parts as intervention opportunities is important.
Absolutely. That's such a good point. And that is, not everything in a complex adaptive system is created equally. I mean, clearly, everything is connected to everything else, right? So if we were truly going to have a robust complex adaptive system, we actually need the universe. So we can't use the universe, so we need to cull down and see what's most important. But a very effective method for that culling down is what's called sensitivity analysis. So you can change your various assumptions, and this can now be done in an automated fashion. You can change various assumptions and see if it does indeed change the system very much. And for a particular agent, let's say, if you change the parameters wildly for that agent and nothing happens at all, that's not a very important agent, so you can let that one go. For another agent, you could tweak it just the littlest bit, and it's going to have wild ramifications perpetrating through the system. And so that's a very important, very strongly, heavily weighted agent, and you need to model that also much more carefully than the less important agents. Does that get to your point? Great. All right, if anyone else has questions or comments, please come on down. I wanted to leave this also with you. This is my email address. If you have any questions you would like to ask of me and you can't do it right now, please email me. I respond very quickly, and I love getting good questions. So please. I hope I'll be back. Thank you. Good.
That's very complicated what you just explained.
Thank you. Hi. You're very welcome. Who are you?
My name's Tara Weinberg. I'm a third year epidemiology doctoral student.
Okay, yes.
So I was wondering a little bit more about when you're building your models. It sounds like